Thank you, Dr. Shubhangi, for giving me the opportunity for a wonderful session. I'm very sorry I have to break the queue to come back up here. So I'll be just talking about a bit about paralytic strabismus, and the best and the worst part is that there are no rules, so I can't give you any rules. A fair amount of patients, anyway, we just discussed, have a chance of recurrences or inadequate outcomes in complex cases, whether we're talking about paralytic strabismus or we're talking about restrictive strabismus. Obviously, the chances are far, far greater, and there are really no standard rules. Your workup becomes the single significant most important impact when you're planning. So if possible, unfortunately often we don't get that. What was the original deviation? So how much was it that was corrected? It will give us an idea of what was the impact of that surgery that was done, because you'll get an idea of what was the status of the muscle. Because in paralytic strabismus, you're not really dealing with the normal conventional dose response curve. So you are going to struggle with your planning. So that's where the first modification will happen. Details of the surgical procedure, what was done, what is the duration of the time, because over time, again, paralytic strabismus or even comitant strabismus muscles tend to adjust to the procedure that has been done, and their tonus and the adjacent tissue changes happen. So again, that has an outcome, an effect on the outcome. What was the course? So did it remain aligned? Is it a drift? Is it that there was no that there was this much amount of residual? So these things are key questions we want to ask. Of course, systemic factors, any cardiovascular related issues, any blood flow related issues, because often in paralytic strabismus you may be landing up doing the third muscle in that eye, or because of so it's important to identify anterior segment ischemia. Any slip muscle or excessive recessions that have been done, or excessive resections have been done, which is going to have an effect on the palpable fissure. So excessive recessions are going to have widening, excessive resections are going to have narrowing. So these are things that not only because of the paralytic strabismus and abnormal innervation, say in third nerve, that you have palpable fissure changes, post-surgery you're going to have something like this. So what was the kind of surgery? So a slit lamp examination is a must. Identify which muscles were operated if you don't have the record. Identify what kind of incision was made, because that's going to tell us how much fibrosis to expect. So if there was a fornicial incision, you know that there will be a little bit of fibrosis near that fornicial line. But if it was a limbal, you may have to dissect accordingly from the limbus and maybe have to clear a little more tissue on the sides. AIOCT was mentioned. It is definitely a useful tool in your planning. You are able to fairly well identify whether a muscle had been operated previously or not. But of course, there are challenges. The accuracy levels are less. It's obviously best if you have your records. Usually, if you're going in to reoperate, you would prefer a large limbal opening, because you don't know where the muscle exactly is going to be, what are its adjacent tissues. There may be a fair amount of fibrosis, and you're going to struggle to open it up. So, I mean, obviously, the surgical process can be fairly challenging. Let's just run through some of the cases of challenging paralytic strabismus, and I can just tell you how I have thought about in these cases. May not be the best, and there are, in these challenging conditions, they may be hugely different, but far more effective idea. So this was a left residual third nerve palsy, no records available. You can see that there were suture marks there on the medial and the lateral side, possibly showing that a recess resect procedure was done. Obviously, we have a whole gamut of options now available for managing complete third nerve palsy. But the fail-safe surgery, which I have found, and in many of these third nerve cases, you will see that I have operated, I have preferred a globe ankle to the medial orbital wall, accompanied with a large lateral rectus recession. For almost all the others, there are a lot of challenges. If it's already been operated and it's likely a large recess resect procedure has been done, you are not going to gain too much by going in and doing a little more nudging here and there. Lateral rectus periosteal fixation with an MR resection is again another possibility as a resurgery, especially even if previous surgery has been done possibly on the same muscles. But as we discussed, doing a modestly more amount of medial rectus plication on a poorly effective medial rectus really is not going to give us too much of an impact. If the lateral rectus is still significantly effective, then maybe a periosteal fixation may help. But a globe fixation to the medial orbital wall is almost a sure shot way of correcting it. If the lateral rectus has been previously operated, really I would not recommend even trying the nasal transposition of the lateral rectus, because you are not going to succeed. It's almost likely. So, as I mentioned, this was this was the surgery. The forced duction test was positive. We just did a large lateral rectus recession with a medial globe anchor. So, like I said, this is a very fail-safe surgery. The downside is, of course, you don't get any movement, but there wasn't any much to start off with, so you get great results. Of course, there is no effect on the ptosis. Again, another patient with a third nerve palsy, so you can see a large exotropia with very little medial rectus function. Horizontal muscle resect procedure was done. Again, you can see that there was hardly any impact. And we went back and did the medial orbital wall anchor. So we just required one side to be operated, because very recently the lateral rectus was operated. So do a forced duction test. Make sure that the FDT is free before you attempt any kind of a strengthening procedure on the antagonistic. So again, another third nerve palsy. But this was a previously operated medial orbital wall periosteal fixation done by me. Unfortunately, it failed. This was one of our initial planning. So now we kind of overcorrect in the initial go itself. So we did this. You can see that very quickly she just came back with a fair amount of recurrence. And this was definitely not what she was willing to accept. So we went in again and did the same surgery again. So a medial periosteal wall fixation can be done even in these cases. So as I mentioned, this is a kind of fail-safe surgery I always turn to when you have unhappy patients and you don't know what to do. So we went in again, we removed all the sutures and fibrosis, and went in and repassed the non-absorbable through the medial wall periosteum. This is just another, you can see that a residual third nerve bilateral lateral rectus recession had been previously done. We did a large plication. Again, not such a great intervention in a third nerve palsy, but definitely better than what he came in with. So that was for third nerve palsy. Like I mentioned, the medial wall periosteal fixation is a fail-safe. I have even done it in a failed nasal transposition of split lateral rectus. So in all possible previously operated, this surgery gives us very, very good outcomes. This was a patient of bilateral sixth nerve palsy. Somebody had outside done a conventional 5 millimeter approximately bilateral medial rectus recessions about a month or so ago. Really, you don't expect anything to happen in a bilateral sixth nerve palsy. You can see his significant head posture. He had left eye, that was the fixing eye. The right eye had subnormal vision. This was post-traumatic, so he had subnormal vision because of the trauma on the right eye. We decided to tackle the left eye first, a staged one eye followed by the other. We decided to manage the left eye first, because that was the seeing eye, and get him to get rehabilitated and start doing performing his routine activity. So intraoperatively, we could see that the MR was, the FDT was free, recently operated, but I still went in and did a little more MR recession, and I put this on an adjustable short tag nose technique. So by this technique, you can do fornix, although in this we did not do a fornix. I went in limbal because it was previously operated and the limbal opening was there. So we just had to quickly cut. There was not too much fibrosis. So a short tag nose, the advantage of that is that if you don't want to do anything, you don't have to touch the patient the next day, along with a superior rectus transposition with a posterior fixation suture. So post-operatively, you can see now his head posture was good. His left eye, he was looking straight. His, of course, it did not add too much to his abduction, but the patient was straight. So now he comes back a month or so later. This was, of course, so he comes back a month or two later for the other eye. We do the same procedure in the right eye. So put the right eye medial rectus on an adjustable short tag nose, 7 mm, with an SRT with posterior fixation suture. Unfortunately, there was a little overcorrection in this eye. So you can see there is a little exo. So I went back, did an advancement, and he was pretty comfortable. So, of course, immediately next day, we just advanced that short tag nose. So he was pretty effective and happy. So again, you need to know what has been done so that you can make your planning appropriately. This was a post-traumatic medial orbital wall fracture with medial rectus entrapment. He had undergone medial wall repair with a lateral rectus recession. Our procedure, which we preferred because obviously one muscle had been already operated, he had suffered trauma. We're not sure what was the status of the vascularity. We did the superior rectus and the inferior rectus Nishida procedure to shift it as much as possible towards the medial rectus, and you can see great effect. Not so much great as far as adduction is concerned, but great primary gaze alignment. This was a patient who had good vision, so at least he was diplopia free in the primary gaze. This was a patient with congenital aplasia of the inferior rectus. You can see severe hypertropia. He had undergone some time back a superior rectus recession, which would be the first surgery of choice. Unfortunately, there was no significant improvement in this patient post-surgery. We just did the imaging to actually confirm that there was aplasia, because I mean, then we would take a call on what else to do. So again, in this patient, we did an inferior oblique anterior positioning Elliott and Nanking technique, where we place the inferior oblique right adjacent to the inferior rectus, along with the inferior Nishida, and you can see that this patient had great alignment and a fair amount of depression also. So again, this is a great surgery to use when you want to possibly spare the vessels from any problem. This was a patient who had operated, and sometimes we get, I mean, we all have faced these nightmare conditions. This was a residual hypertropia with operated scleral buckle, with a buckle explant, with significant inferior scleral thinning, and you know, a lot of things had been done. Superior rectus recession had been done as a previous surgery also, and she was extremely unhappy, and she definitely did want, the vision was not there, but she wanted some cosmetic, and all we did was make the inferior oblique anterior positioning with +2 station. So we anterior positioned the inferior oblique, and it brought great primary gaze alignment, not so great depression, but at least the patient was satisfied. This was a child, came to me at 2 months with hypotropia. Just sudden acquired hypotropia. No, I mean, we had his early 1 month, 2 month photographs of absolutely proper alignment, and at 2 months the hypotropia happened. No idea why it happened. We followed him up for a couple of months, steroids, everything, just wishing and praying as much as the mother was that, you know, he doesn't have to come back to us, but that was it. We did an IR session. He was again okay for a period of time, and then a couple of months later he comes back with the same thing. We did a 12 millimeter recession of the inferior rectus with a nasal shift. Remember, whenever you're doing inferior recti, if you go beyond 4 to 4.5 millimeters, always do a nasal shift, otherwise you're going to generate an A pattern. So post-op, this child was great. He's been following up for a very long time. Unfortunately, his vision is not so great. He did have amblyopia during that period when we were managing him despite giving occlusion therapy, but he had amblyopia. So kind of just summarizing all together, resurgery, paralytic strabismus can be a challenge, so resurgeries can be a greater challenge. You need to get all the information you can get. You'll have to customize surgery. You need to see what is the best custom fit for every surgery, every patient, and you may sometimes have to improvise intraoperatively. You'll find a lot of surprises. The force duction test may be positive in a muscle you were not actually expecting. Muscle may have been operated which you were not sure or you had not bargained for before. Preferably use limbal incisions, get a good exposure so that you can get the whole muscle. Sometimes again, muscles may be in places, hiding in places where you are not really sure. Inferior oblique does that to you. Very often you may have to actually run around to find it. And finally, force duction test, both intra and post-op. Thank you very much for the opportunity.
Thank you. Thank you, Dr. Rohit.